delighted to have the opportunity to talk to you this afternoon on today, Friday. And I'm going to give you a perspective from the National Institute of Minority Health and Health Disparities. I want to thank the organizers of this meeting, symposium. I have been to Nebraska, not to Lincoln, but to Omaha. And I very much enjoyed the time I spent there, both visiting the medical center and doing listening sessions for our strategic plan several years ago. So I want to start with a big picture perspective of what I think science can do to help reduce inequity or health disparities. First, we need to get on the page of standardized measurement of social and demographic factors that affect health. Many of these are self-reported. We can do standardized surveys. We can do standardized ways of asking the questions and not allow individual investigators to say, I prefer it this way or the wording that way. We have to really align on that in order to be able to combine data. The reason also is that discovery science through big data is here. And not only do we need more data scientists and more diversity in data science and better linkage of data, but it starts with the quality of the data that gets collected. When one sends genetic sequences to be deposited in dbGaP, those are predictable ways of collecting and analyzing data. We don't have the same approach to, say, collecting data on socioeconomic status or race, ethnicity, or even many of the clinical outcomes that we care about. From my institute's perspective, the science needs to be an engine for promoting diversity of the scientific and clinical workforce. I'll come back to this. We have evidence that this makes a difference, particularly in the clinical workforce, and we really cannot afford to wait much longer to see this improve in a substantial way. The COVID pandemic, as I'll share with you, really brought home the importance of community engagement and how we cannot expect to improve the public's health without having an established way of having sustainable, trustworthy relationships with our communities, whatever they are. Actually, from NIH, we look at it from a national perspective, but each local, regional area will look at it from their perspective. And finally, I think implementation science needs to be much stronger. We need to implement what we know works. We have proven many things, but often fail at getting that implemented in a broad way. It's never going to be 100% for almost anything, but we do need to do better, and I'll have examples on that. And MHDI defines the populations with health disparities. Actually, the first three bullets on this slide were defined for us by the Congress when they created the center that became the Institute in the year 2000. So all racial and ethnic minority populations define the census, all poor people of any race, ethnicity, all persons who live in who are underserved and live in rural areas. That's applicable, obviously, to the state of Nebraska. And in 2016, after a process that preceded my arrival at NIH, sexual and gender minorities were declared to be a population with health disparities. I have the statutory authority to be the sole person to decide that. Of course, I have to listen to my bosses in concurrence with the director of the Agency for Healthcare Research and Quality. We believe there's a unifying factor of a social disadvantage that results from being both subject to discrimination or racism for all of these populations in some way and being underserved in healthcare. They're also all not condition related or disease related. They're identity factors or social economic factors or geographical ones. We have used the approach that a health outcome that is worse in one of these populations and compared to a reference population is what we said defined a health disparity. I put that in italics because we are reevaluating that to think about setting a standard that would be defined by national criteria rather than always assume that the reference population has to be the better health outcomes. So why race, ethnicity, and socioeconomic status? These are the two fundamental pillars of the research that NIMHD is interested in or funds. It predicts so much that we don't understand that we need to measure it in a standardized way and consider it in any clinical care or research with human beings. That's my position on this, both for the smallest clinical studies in a research hospital, such as the one at NIH, to big population studies. And race, ethnicity, self-identified, socioeconomic status measured usually with educational attainment is the easiest one, although there are a variety of ways. Other examples, African Americans in a observational cohort study have twice as many strokes compared to their white counterparts for the exact same level of systolic blood pressure for adults between the ages of 40 and 64. And this is unexplained. And we should do a better job of controlling blood pressure in this population because they actually do worse than their counterparts. We know that most chronic diseases are more common in people who have less privileged socioeconomic status, and it isn't because of bad behavior. There are structural factors that are the major contributors to this. Again, we need to address that. And finally, in an example done over a decade ago now from the Kaiser Northern California Diabetes Registry, all racial and ethnic minority populations in that registry, and this is a registry of about 65,000 patients with type 2 diabetes, had about 30% less heart disease than their white counterparts with type 2 diabetes, but twice as much end-stage renal disease. Now, I don't think that anyone has an explanation for this. It's not an obvious biological or healthcare delivery or medication adherence difference within this health system, especially with this size of a study. So these are examples of how these factors matter. This is data from about a decade ago, mapping mortality, total mortality to household income. Now, we've known this for over a couple, 200 years. If you're poor, you're more likely to have disease and die prematurely. And this data shows 3 times more likely to have mortality, all-cause mortality, than some household of 4 that has an income of 115,000. Less than 25,000 is the poverty level. Not many clinical factors have this kind of gradient. Perhaps body mass index at the very high level, systolic blood pressure, tobacco smoking, but not too many other ones do. And yet we don't often measure that. Here's an example of stratification of why it's so important to look at these two things in comparison. These are data from the CDC on obesity in youth by educational level of the head of household, which presumably reflects the socioeconomic status of that household. And what the comparison is of the head of household having less than high school education compared to a head of household having college education. So whites will improve, the youth will have 7.3% less obesity among the males, and a head of household has a college education. So that's how to interpret this slide. You can see the differential effects by race, ethnicity. Independent of where they absolutely begin, we know that both Blacks and Latinos have the highest rates of youth obesity. And we see that the benefit among Black, both males and females, is less of educational attainment. It's pretty good for Latinos, but still less than whites, especially for the females. And for Asians, you can see the benefit as well. Another example of stratified data in tobacco smoking, not a whole lot by race, ethnicity, higher for American Indian, Alaska Natives, lower for Latinos and Asians by a significant amount, but Blacks and whites are about the same now in terms of tobacco use. But we notice that there's a tremendous gradient of education. So if you're up to a high school graduate or less than 12th grade, It goes from 35% to about 20% to 7% if you have a college degree. And I think this is a lesson of why this education is so important. Now, at NIH and MHD, we have created a social determinants of health measures website called the Phoenix Toolkit. We latched on to a process that had begun by one of the other institutes, the Genome Institute, and we created our own webpage. The link is on the slide. You can have these slides. And we gathered the demographics that were already on the Phoenix site and the individual measures. We expanded some of those and really have been working on developing measures of structural determinants. This is a process that takes about 1.5 years for each phase. We do it internally first, select constructs, and then have an expert committee that reviews all the data and makes a decision on which ones are ready to go on the website. And we encourage all of our scientists to use these. We also have a research framework that we developed and the staff developed in 2016. This is published, and this is meant to be like a roadmap, a guide to where we should be going, where your research might be. This is not causal or comprehensive. And so it really emphasizes levels of influence, both the individual all the way to societal, and then the different domains of influence from the biological and behavioral to the built environment, social cultural environment, and very important, the healthcare system. The healthcare system being most important for people with chronic disease and on chronic medications. We still fund the majority of our grants in this column, the individual column. And so more work needs to be done to move some of our funding, some of our research funding to the others. Let me share some work that we have done at NIMHD in collaboration with other institutes. This is leveraging a contract we have with the Institute for Health Metric Evaluation. They developed a global burden of disease project looking at comparisons or across the globe, across the planet of different countries. They're mostly funded by the Gates Foundation. We funded them to look at sub-regions of the United States by race ethnicity. So this is a map showing life expectancy, race ethnicity, Black, American Indian, Alaska Native, Asian, although Pacific Islanders are included, and Hispanic, Latino, compared to whites. And if you're in the bluish purple color, you're doing better than whites. And if you're in the yellow brown area, you're doing worse than whites. And we can see for Blacks, for the most part, it's worse. But guess what? There are pockets of the United States where African Americans actually do better than whites. And you see these light purple ones. American Indians, mostly worse. They have a shorter life expectancy than African Americans. But again, you see some areas where they do a little bit better. And with Hispanic Latinos who have had a longer life expectancy pre-pandemic, we see these areas in the Four Corners, in northern Arizona, the border, the Rio Grande Valley, where they're actually doing worse. And with Asians, we know longest life expectancy and do generally better than whites throughout the country. Now, the pandemic was, well, an incredible year, 2020. This is a product of the NIH intramural program at Cancer. We collaborated on this paper in the Annals of Internal Medicine. They quantified the excess deaths. Not all of them were directly related to COVID based on death certificate assignments. And they're also 2 to 4 times more common. We already knew that. African Americans, American Indian, Alaska Natives, and Latino Hispanics. Males did worse than females. That's well established. And we see that as a global group, Asians actually did okay in terms proportionally compared to the general population. I do want to make the point that since whites in the United States are the largest population group, they had the largest burden of absolute deaths in both males and females, as you can see from this slide. However, we should be proud of the fact that in September of 2022, these age-adjusted death rates by race ethnicity had become almost identical, at least for Asians, Hispanic, Latinos, and African Americans, Blacks. American Indians remained higher, although they're not shown in this slide. And these are data actually synthesized by the New York Times, because the CDC would not do age-adjusted death rates. But you take the CDC data and show the crude death rates, you see the same thing. I think we need to be happy that part of this is due to control of having more level vaccination rates by the summer of 2022, as well as attention to better care in the hospitals of our patients with infections. The NMHD intramural program conducted a nationally representative survey using YouGov to do online survey just around the time the vaccine was being rolled out. It was stratified by race, ethnicity, and intended to get at racial ethnic minorities and also Latinos who spoke Spanish and did not speak Spanish. And this was a COVID-related discrimination. It stands out that Asian Americans, as you might suspect, had the highest proportion, given what was going on in the country at the time. We can see, though, that all racial and ethnic minority groups had higher rates of COVID-related discrimination compared to whites. And so this is published in the American Journal of Public Health. The pandemic also brought us an acceptance by insurers, as well as many patients, of telemedicine. This is something, I'm a general internist by background, and we tried many times to start getting telemedicine incorporated into primary care. It was really hard because no one would pay for it. Well, now it's getting reimbursed. But there is a caution that what happens with telemedicine is who's less likely to use it? The most disadvantaged populations, older adults, those who don't speak English, somewhat males, Medicaid, low middle income, Asians in this analysis, as well as Latinos and those who are multiracial. So as we accept telemedicine, and there are other data that say 40–45% of racial and ethnic minorities like telemedicine accept it, we need to attend to the issues of cost of using data if you're doing it on your phone. Many of these households don't own computers. They use all their digital access and web access through personal devices, mobile phones. Now, COVID also really brought a crisis about community engagement, and the NIH response that was led by NIMHD and NHLBI, the Heart, Lung, and Blood Institute, was something we call SEAL with a C. So it's Community Engagement Alliance Against COVID-19. We hope and expect the SEAL will have a long-term life. We focused on the areas of the country that seem to have the most disproportionate burden of COVID-19 in racial and ethnic minority populations. So the blue states in this case reflect the first set of teams that we funded. The sort of yellow-orange color is the second set of teams, and we have sustained these 21 teams to continue work, and are now evaluating where we go with this network next. Since COVID will hopefully, well, we know it's not going to be with us forever at the rate that it was in 2020, 2021, and we are already beginning to work in areas of maternal morbidity, mortality, as well as the effects of climate on health. But SEAL's fundamentals is really in this point number 3. We need to move at the speed of trust. We need to build trust with our communities over time. And this has got to be sustainable and real. So we don't go in with, here's a great study, why don't we sign up for it? And then after the study's done, we see you later and you hear from us in a couple of years. We have to be present. We have to be in the neighborhood or in the community. And hopefully some people living there. We have to work with leaders that are local, both faith-based leaders, health leaders, community organization leaders, commercial or business leaders, everyone that has to be part of this in order to make movement in a community. One has to be part of it. Those are the principles that we go by. There are going to be hiccups. There are going to be bumps. NIH has not been used to doing this on this scale at all. There have been efforts in the past from other institutes, maybe success to some extent, but no one has said, well, we got to keep doing this. Well, Dr. Gibbons and I are very committed to continuing this. We have appropriations to maintain it. We have to see how we run it and direct it. And I will point you again to our website that has a wealth of information. We have mostly focused on communication aspects, surveys, mobilizing people to consider being part of studies, awareness of issues around long COVID as well. And now I would say, you know, if we have another surge of respiratory infections at some point, to do test and self-test with the home test and treat with what are very effective antivirals. If you want to read about sort of the general NIH response to COVID, Dr. Collins put together a nice summary for, it was published in the Journal of Science earlier this year. It does mention SEAL, but it mostly focused around the issues around the vaccine development and setting up the network of the private-public partnership to do clinical trials. Let me turn to the topic of racism and discrimination. Obviously not an easy one to talk about. And I think the point here is that these are data from 2015, first of all. So this is way before anything happened with COVID or any of the other social unrest that we experienced in 2020. And this is a question posed by the Kaiser Family Foundation survey, national representative sample. So in the past 30 days, were you treated unfairly because of race or ethnic background in a variety of settings, including healthcare? And you can see that 53% of African Americans basically said yes to this, and 36%, over a third of Latinos said yes. So, you know, we have a problem, and we clearly haven't, you know, resolved this, or haven't even want to talk about it in many cases. Now, 2020 has come and gone. Sort of the peak interest in this has passed, but as an agency, and certainly as an institute, we really are keenly aware that this is important to think about. And since what we do is research, presented to you as a research construct. So almost everything has been done with racism is under the interpersonal umbrella. We have good measures. They're on the Phoenix website. It has been associated with a lot of outcomes, including cardiovascular outcomes, as most of the data are on behavioral outcomes or substance use or mental health outcomes in both youth and adults. And not to mean that that's all done. I mean, there's still ongoing work here. Harder is to think about internalized racism, where someone just says, no, I've never had problems with racism. They've internalized it either cognitively or biologically. Some of the efforts on that look at allostatic load or telomere length or other ways to measure this. Among youth, perceived racism or discrimination is one way of evaluating, and there's at least a couple of studies that have done this successfully. And then one that is really almost untouched is secondhand effects. What is it like to be around someone who has been a victim of racism? What's it like for a child to grow up in a household where that's the case? And we haven't really factored this in much of the early childhood development research that we have done. But there's also structural racism that's a consequence of policies that were implemented in our country at another time. This is just an example of residential segregation built on the policy of redlining, implemented in most U.S. most U.S. cities, where in the 1930s, so in the post-World War II economic boom the United States experienced, the way to build wealth for a family is to buy property. And in that time, banks would say, well, you live in highest grade residential property, well controlled and restricted, you're going to get a good loan to buy your house, back when houses cost $10,000. And if you're in type H, it represents Negro developments in lowest grade. These are documents from the U.S. National Archives. This is a map of Washington, D.C. This is what Washington, D.C. looks like today, white and black. It's very segregated areas, even as Washington itself has evolved. And we see differences in, apologies, in life expectancy across the city that can be over 10 years, in some cases 20 years. You've probably heard the saying that your zip code is more important to your health than your genetic code, as a public health saying. And this is based in large part on the data like this. Other examples of structural factors, these are data from New York City looking at maternal morbidity, severe maternal morbidity. So mortality is relatively uncommon. Let's say up to 1,000 women die in the first year after giving birth, or as part of being pregnant. Maternal mortality, but there are probably 50 to 75,000 cases of severe maternal morbidity. So easier to get some data on this. And this is Elizabeth Howell, who did this work several years ago. Low Black serving hospitals in New York City, where hospitals are relatively segregated, you can see that Black women in these hospitals had a lower rate of severe morbidity than the white women going to the high Black serving hospitals. So is it the women or is it the structure or is it the hospital? I'll leave it open, but I think the indicators here are that this is a structural problem of the hospital. This is an interesting, sorry for the busy slide, but it's basically a randomized trial taking only 60 African-American patients with type 2 diabetes. This is from a group in Wisconsin, in Milwaukee. And they were randomized to different amounts of money that they were going to get. So this is financial incentives, so cash assistance. So to improve their diabetes, and they were interested in seeing, well, what's the frequency of giving the money, the financial incentive that will make a difference. And at the end of only a follow-up, it was designed to be only 3-month follow-up. The hemoglobin A1C, the measure of glucose, had dropped by 1.74% with either moderate or high frequency. This is a big change. This is the kind of change we saw with the big diabetes trials, 1.5% to 2%. And so it's a very provocative data, just a proof of concept that perhaps this is a kind of intervention that may actually yield better health if we provide that support. NIH has a program called COMPASS. These are the Community Health Equity Structural Intervention Initiative part. These are currently being reviewed. We had a tremendous response to this, and there will be more coming on this. This is through the NIH Common Fund, and I'm one of the director co-chairs of this effort. Another example of implementation science in this case, this is what happens with hypertension control in pregnancy. We know that if we treat hypertension in pregnancy or in any condition, you get better outcomes. This is a randomized trial in the New England Journal of Medicine. Active treatment versus just let's see what happens with, we don't want to get use too many drugs in women who are pregnant, and unless blood pressure got worse. And we saw the outcomes improved by a significant amount in terms of severe preeclampsia, preterm birth, and placental abruption. So we clearly, again, implementing what we know is a major part of decreasing disparities. As I said, I practiced medicine for 37 years, was a primary care doctor, and the power of patient-clinician communication is hard to quantify, hard to measure, and I think it really does matter. And we're interested in that area also as a research. It is directly linked to patient satisfaction scores, better adherence, improved health outcomes, and in a very well done study with orthopedic surgeons, fewer litigation events with when bad outcomes did occur. We think that race concordant visits are good, race ethnic concordant visits, and Lisa Cooper, who is at Johns Hopkins, did some elegant qualitative studies doing audio recordings of interactions that showed that African-American patients seeing African-American doctors had 2 to 3 minute longer visits and more patient-centered by standardized measures. The medical expenditure panel survey shows that African-American and Latino and this is funded by the Agency for Healthcare Research and Quality, and it's a population-based study of people in healthcare. And African American and Latino physicians care for more than half of the racial ethnic minorities in that cohort, and over 70% of those who speak limited English, and more Medicaid uninsured patients. There's other data that support the fact that that minority physicians are more likely to work in underserved areas, more likely to take care of uninsured patients, and more likely to take care of Medicaid patients. And despite that, we have enormous barriers to improving on the fact that only 14% of medical school graduates and 12% of practicing physicians are from underrepresented groups, populations. This excludes Asians, but if we can include underrepresented Asians, people from Southeast Asia, and definitely Native Hawaiians and Pacific Islanders, who are a different group, we can see that the same holds for those groups of physicians. Now, I am fluent in Spanish, and I spoke Spanish a lot when I was taking care of patients. And we know that if you don't speak the language, and I had patients who spoke Russian or Chinese, you use an interpreter. So what happens when you use an interpreter? Well, you triangulate the visit. Encounters take twice as long. So you end up doing half as much, because no one's going to give you twice as long to do a patient visit, right? So you take care of the technical things, and not you don't build that sort of relationship with patients, or it's much harder to do so. Good studies have shown that when using interpreters, patients generally ask less and say less and answer less, even when the interpreters are professional. They're more passive in the visit. Who translates matters. We should always use professional interpreters whenever possible. This is an unfunded mandate. I recognize it, but if you have a population, significant number that don't speak English, this should be a priority for the system. It's a matter of accuracy and quality. And then there is now technology to make it easier. There has been now for about a decade, using dual headset telephones in the hospital when bandwidth issues are a challenge, or video conferencing. And digital translators are okay for some things, but probably not quite ready yet for patient visits, but are better than nothing if that's all that one has. And then if the clinician says, oh, I speak that language, make sure that they are tested and certified, and if possible, compensated. Now, NIMHD holds an annual summer institute, as we call it at NIH, where we bring in early career scientists for a week. We've done it virtually the last 3 years, 2021 and 22. We're going to do it in person again this year. We do some selected lectures by successful scientists and role models. We do a mock grant review with a real grant, with permission, of course, and that's usually one of the favored activities. We have a writing seminar that AAMC helps us with, where they meet with staff, and that's probably also the most valuable thing, in that they get to network among each other, as well as with NIMHD and other NIH Institute staff. We asked them to, in the application, to write like an idea that they would submit a grant for. We asked them to say they're committed to submitting a grant. We want to see this as a way of developing the next generation of scientists in minority health and health disparities. I love showing this picture. That's one of the attractions, one of the good things that Zoom brought us, to be able to get one of these shots. Maybe this year we'll get one in person. So let me wind down to give time for conversation with a few highlights. How do we promote equity in healthcare to reduce disparities? It starts with access. You need both insurance and a place and a clinician. These are all fundamental. The Affordable Care Act experiment has been effective at reducing uninsured by about half. And it held over the last several years. There's efforts now to continue to strengthen it. If the North Carolina approval goes through, when they file their budget, there's 10 states that are without expanding Medicaid, which is probably in the most immediate impact of the Affordable Care Act, but the exchange also has been an effective way to cover people who can get an affordable plan with the subsidies provided for persons at 400% or less of poverty. So the subsidies can go up quite high. We have public health consensus. We should do it. It's embarrassing to see that blood pressure control, often in the highest risk populations, sits at 60%, 70%. We know we can get everybody up to over 80% with simple measures that require system and teamwork, as well as clinicians and patients. It's not the patient's fault. It's not the doctor's fault or the clinician's fault, but it's combining, a system. We can really get to the goals, whether it be screening mammograms, control of blood pressure, prenatal care. These are things we have compelling evidence to act clinically. I think coordinating systems, there's a lot of promise with looking at navigators and target conditions. We all had patients who were in the emergency room every month, doing working hours. So why aren't they in a clinic, in a system? Or is it anxiety that's leading them there? Or are they so sick that they're needing help frequently? And then in that case, can we go to their home to take care of them, or bring them in, preemptively to clinic? And these are target conditions that can be generated. It takes the system to identify those individual patients, and then a team of clinicians to help take care of them. We need to strengthen patient-centered care. This, I think, starts with primary care. We have not had a healthcare system in the United States that is centered in primary care, but some primary care clinicians can have effective communication, cultural competence, and then you need an effective referral neighborhood of secondary specialists. Of course, tertiary and quaternary care are also important for other less common problems that need that kind of level of care, such as a transplant or open heart surgery, or a variety of contexts. But we need to strengthen that. That would be a direction, that's a policy decision that would have to change. We need to leverage health IT and the electronic health record to really address equity. This may mean proxies to use the portal, may mean more use of videos for patient education. There are a lot of systems that have done a good job to do this. These systems are really good now. They're going to get better. They talk to each other. There's a tremendous amount of interoperability, and it makes the clinicians able to see what happened at that medical center across town, but also the individual patient can go to two places and see that their data are in both. And in thinking about performance measurement, I know that CMS has been thinking and working on this to develop a quality measure that systems can be held accountable for. Looks like I'm going the wrong way. And so not only do we put, how we've done these incentives, we say, put money on the table to see if you lower the length of stay, you'll get so much money. If you don't, you'll get penalized. Well, let's do that. This kind of performance measurement for equity, and see where we go. We can get changes in that. Community engagement, I discussed this already with the SEAL model. Again, thinking about population health and primary care, and thinking about health and not just health care. Probably 50% of adults and easily much higher proportion of children don't need to see a clinician on a regular basis that often. I mean, that regularly, especially adults. They preventive care that one can initiate yourself. But once you get a chronic disease, you're really dependent on the healthcare. So we need both. We need emphasis on healthy communities and health, but also we need a functional community clinic or health system that will care for people when they get sick or when they develop a chronic illness and are really dependent on regular care. engaging community resources to really work towards getting healthy food, safe places, better housing, these structural factors that really matter to improve overall health. I'm going to end just to share some of the data about the MHD. Our budget has grown over the last several years. We got a special increase in fiscal year 22 to do more research on health disparities, and again in fiscal year 23. Most of our increases are tied to a particular program. So it says you're getting more money for doing this particular thing. And that's about half the time at NIH. When it comes to it just an increase, then we're able to fund more scientists. And that's what we did in fiscal 22. Our R1 rate funding, these are research grants, went up to 18%. A success rate, this is comparable or it's closer to where I would like us to be, around 20%. It's really not good to be down around 10%, which is where we were a couple of years ago. So future directions, I would say always thinking in multi-level interventions. To put it simple, we're not about giving a drug or placebo to someone in our interventions. We're thinking, well, we want to change behavior, but in the individual, but we also may have to work with the family, or if we're working in a health system, we work with the system and the clinician and the patient. We emphasize intersectionality. I showed you the populations with health disparities. Our two pillars are race, ethnicity, and socioeconomic status. And we look at this intersection with the other populations with health disparities, particularly in the case of rural residents and sexual and gender minorities. We want to identify mechanisms in all the different domains. And we do have a division that focuses on mechanistic research, behavioral as well as biological. I emphasize the communication, the importance. I think it's an underutilized intervention to achieve change, as long-term relationships that individuals may have with their clinician. And finally, the whole notion of structural change.